All right, so abnormal neuro assessments. So we're looking at those cranial nerves being impaired, which can tell you might have some brain death. Before brain death, usually you're herniating onto those cranial nerves. You'll see some pupillary changes. You'll see some reflexes that get affected, right? And something that's not really, yes, you can control your respirations, but there are neurorespiratory patterns. As we start compressing the cortex, start compressing the pons, which are responsible for a lot of our respiratory centers, right? We kind of touched base on level of consciousness and how to assess it back in the normal assessments, right? We look to see if someone is stupor, lethargic, semi-comatose, etc., or we use the better scale known as the what? The RAS scale, right? The Richmond Agitation Sedation Scale. And we use the Richmond, otherwise it's called a what scale? That scale. All right. So respiratory patterns, right? So respiratory patterns originate in the pons, right? The medulla sets the respiratory rate. It says you're breathing at 12, 20, 36, or 4, right? It tells what the rate is going to be. And then that signal then goes to the pons, and the pons decides the rhythm of it, right? So the rate or the beat of the respiratory rate is 12 breaths a minute, or 18 breaths a minute, which is whatever it charts, or is 22 breaths a minute, right? So that's the rate or the beat at which it goes, right? Whereas the rhythm, and this is an annoying thing because I'm a music major, is that people always say, oh, I like that beat. So you like 120 beats per minute? What does that mean? It's like 120 beep 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 beep. No, you like the rhythm. You like the is it what's the pattern that the music is going at, or the respiratory rate is going at, right? Because normally you inhale for how many seconds? Or what's the ratio usually? You inhale for 1 second and exhale for 2 seconds, right? So it goes in for 1, out for 2. That's if you're breathing 20 breaths a minute. So 1 to 2, that's 3 seconds. 20 times 3 is 60, right? 60 seconds. That's perfect for 20 breaths per minute, right? But what if you're breathing 12? Now it's not 1 second anymore. It's a little bit longer, like 1.4 or 1.3 or something. So that inhalation-exhalation pattern is what these pontine centers, pontine nuclei, decide upon, right? And also you might be inhaling, and your body's like, nope, that's way too much. And it will actually say a little negative feedback and say, with little stretch receptors, and say that's too much, right? You need to stop inhaling, right? Or it could hurt. That could be another reason why you would stop inhaling as well, right? So there's little mechanical receptors that are out there that tell us what's going on out in the periphery, right? If they start getting filled up with fluid, for instance, right? That's going to start raising your respiratory rate because you're not getting a lot of oxygen input as well. And also, you know that you don't have oxygen when you have little carotid O2 chemoreceptors. Also, you have them in your medulla as well that are assessing the O2 levels at all times so they can start raising the respiratory rate. Because we know if the O2 is low here, it's going to be low in my big toe. It's also going to be low in my brain. So that's what sets the rate. And then your pons like, oh, the rate's going to be 36. Now we're going to be going fast, right? We're going to be doing a 1 to 2 pattern at a faster rate, right? So we have rates, tachypnea and bradypnea. So tachypnea is usually due to SNS stimulation, right? And why is your SNS stimulated? We've talked about this several times, but your pH being low, your CO2 being high, your O2 being low, right? You having just a fever or inflammation, right? A surge response of some sort, inflammatory response, fever, and just straight up anxiety can make you breathe faster, right? So all these things are causing you to become tachypnic. Does that mean that you have a neurological dysfunction? Not necessarily. That's a normal response, right? Metabolic encephalopathies can lead to tachypnea as well. Certain patterns, certain ones, right? And then we have irregular patterns of that fast rate. That could be like a midbrain lesion where we're starting to have just a fast neurogenic breathing. We're just breathing fast on their own, and that's just causing a increased stimulation in the midbrain itself, right? And then we have bradypnea or bradypnea. It's where you are breathing slow, right? And why are you breathing slow? Someone could have taken opiates, right? That's usually what you're thinking first. So we walk in the room, respirate is 8. You're like, well, shoot. When did you last get morphine? When did you last get Dilaudid? Is there fentanyl infusing? Right, and they're on CPAP trial or SBT, or they're on the floor and they got some opiates, right? So we're always thinking opiates first, or benzos, right? And then we can think about like hypothyroid, because hypothyroid is what kind of primes your body for SNS activity. And if you don't have any thyroid hormone, you cannot do SNS activity. Therefore, you're being bradypnic, right? And then we talk about irregular rhythms. So irregular rhythms are where you have injury to the cortex, right? So you can't have that normal pattern of breathing, and you have a midbrain or pontine region damage, right? So you have damage to the pons, which is what gives you that 1-to-2 ratio. You might have too much inspiration and not enough expiration, right? Or you might have a change in pattern where they're getting faster, and then it gets slower, right? So we're thinking of like midbrain pons injuries when these happen, right? So you have there's CNS reasons and there's input that would raise our heart rate or lower our heart rate, or sorry, resting rate, heart rate too, but resting rate or lower the resting rate. And that's via our cranium 9 and 10, via those baroreceptors and O2 chemoreceptors as well, right? So when someone's tachypnic, you're thinking of SNS stimulation. Someone put this into a Kussmaul mnemonic, which kind of makes sense, right? And you're acidotic when you have ketones, which is acidosis as well, right? You got fluid overload, you got sepsis problem brewing. All these things are going to cause an increase in my respirations. Is that a neurological problem? Not yet, right? But definitely if you're super hypoxic or super hypercapnic, it can. So irregular rhythms. So now we're talking about fast or slow. We're just talking about the change in speed or the change in pattern that they're breathing at, right? We got Cheyne-Stokes, we got apneustic, cluster breathing, ataxic, and agonal breathing. So Cheyne-Stokes breathing is where they are breathing fast and then they're breathing slow. So if you've taken music, you know that there's a crescendo, decrescendo pattern, kind of like the aortic stenosis, where it starts off slow, or actually starts off at nothing, and then it gets faster, so to a certain 30 to 40 beats per minute, or breaths per minute, and then it slows all the way down, right? So that's called a Cheyne-Stokes breathing pattern. So you can see that in this patient here. So you can see how she's not breathing at all, right? I don't see any breaths happening. I'm kind of looking at the shoulders over here, right? So now you can see, I see a little movement right there, right? So it's getting a little bit faster, and it should be escalating quickly because I know this is Cheyne-Stokes. All right, so you see how she's breathing much faster now. You can see all the abdominal movement happening as well. And then she's going to just not peter out, but she's going to have a slowing of that pattern. So instead of being nothing, which is apneic, to faster and faster, and now it's slowing down dramatically, right? So that's a Cheyne-Stokes pattern. And Cheyne-Stokes patterns happen because of cortical injuries. So the cortex is not giving good input to the midbrain and pons and medulla for that matter. So that's our example for Cheyne-Stokes. Okay, so that's a common pattern you might see. Another pattern you might see is like the SNS misfiring, where you just have a really fast central neurogenic hyperventilation, where they're just breathing really fast all together, right? So somewhere in the brain is just stimulating the medulla constantly, right? It's not because of low O2 or high CO2 or low pH or movement or acidosis. It's because of just a lesion that's pushing on the medullary centers to make it breathe faster, right? And then we have apneustic breathing, and this is due to a pontine lesion. So in the pons here, the second hump, right? So we got the first hump, second hump. First hump is your pons, second hump is your medulla. So we got a pontine lesion of some sort. There's something going on in the pons that's making that rhythm of 1-to-2 ratio abnormal, right? So let's look at this guy here. He's inhaled. The vent's like, it's time for exhalation. Why aren't you exhaling? You're inhaling. They're exhaling. Inhalation was like 10 seconds, and exhalation was like 0.2 seconds. So inhale right there. Exhale and quick inhale afterwards. Right? So that's an apneustic pattern of respiration. Right? That's a pontine. Okay, so a pontine lesion is where you have a really pronounced inhalation and then a quick exhalation and upwards. And that pattern can change, but basically the rhythm is a prolonged inspiration. We got cluster breathing, where you're breathing, all of a sudden they're agonal. Instead of having this crescendo, decrescendo pattern, they just all of a sudden start out at a quick rate and then slow down to nothing. And then they just breathe really fast and slow down to nothing. Instead of having that nice gradual increase respirations and decrease, it's just all of a sudden you have this cluster breathing where they're breathing fast all of a sudden. And then we have ataxic breathing, which is where they're breathing, they just have this, doesn't really have a pattern to it. Whereas like cluster breathing, you can kind of say, oh, they have this pattern every 5 seconds they're doing it. Whereas cluster breathing or ataxic breathing is it's just all over the place. Or they could be breathing normal, like and your ventilators all of a sudden starts going off at you like every 2 minutes. And it's because every 2 minutes they go into this pattern where they just breathe super fast all of a sudden, or that's a weird breathing pattern all of a sudden. And then we have agonal breathing. That's where they are breathing very, very slow. They have no breaths, they're apneic, and then they have a quick little breath, right, at the very end there. And that's obviously a severe insult to the brain. So apneic, not yet, agonal. So it's very slow breathing, like 4 to 8 breaths per minute. These patients usually need to be intubated. This is not something you usually recover from. It's a severe insult to the brainstem, whether it be midbrain, pons, or medulla. We don't know yet, but we definitely know there's something going on, right? A cardiac arrest patient, or they had an embolic event of some sort that can lead to this situation. All right, and then our apneic breathing, of course, is no respirations whatsoever, right? So let me figure out how I did this. Yeah, there's Cheyne-Stokes, where it's breathing super fast, but it speeds up and then it slows down, right? Whereas apneustic is where they have this inhalation and a quick exhalation. And that exhalation time may be very, very short or maybe prolonged. We don't know, but we know the pattern is irregular. Whereas cluster breathing is they just all of a sudden breathe fast and then they're agonal. Ataxic breathing is just all over the place. They're breathing fine, and all of a sudden they are breathing weird. Okay, agonal breathing, as we mentioned, is where they have just a breath every 4 to 6 seconds. Every 2 breath is very, very low, definitely less than 10. Okay, and of course, apneic breathing is where they are not breathing at all. All right, so moving on after breathing patterns are herniation situations, right? So herniation is when you have a movement of our brain where it should not be, right? So it's moving from where it should be to where it shouldn't be. And there's several different versions. There's 6 versions identified here. You can even get like 3 or 4 more if you really wanted to. But basically we are moving things. We can have like a midline shift, like number 3 right here. We all call it midline shift, but you talk to a neurosurgeon, they're not going to call it that. They're going to call it a subfalcine herniation, right? So they're moving from across the falx right here. That's called the falx, and it's subfalx, so it's because it's going underneath the falcine, the little area right there. Is it good? No. It's going to be it can start compressing structures for sure, and eventually, if it can't go left, then it's going to start going down, right? So that's a type of herniation where we are moving the brain from one area to the other. That's usually what we commonly see on CT scans, are midline shifts, right? But the more concerning one is or a more common one is where we have this uncal herniation. Is there an aunt herniation? No. It's an uncal herniation is where you have the uncus, which is what this structure right here is, number 1. So that's the uncus of the brain. And the uncus has moved downward because it was compressed, right? Why was it compressed? There was a bleed of some sort, a tumor, whatever it might be. And it's pushing downward through this space right here, right? And this space between here and here, right? So this space right here, this little space right there, you can see if you take the brain out, you can see what's down there are important things, such as cranial nerve 3, our friend, right? So cranial nerve 3 can be compressed, and of course with later herniations are bad. You want to catch them before they happen, but that's going to start compressing cranial nerve 3, right? And you're going to start getting what symptoms if you compress cranial nerve 3 and cranial nerve 3 can't do its job? You can get a pupil that is dilated because cranial nerve 3's job is to pupil constrict. So it's going to start compressing cranial nerve 3. You notice there's some blood vessels there as well. So you're going to start getting blood vessels compressed. You're going to start losing blood supply to the brainstem, which never sounds like a good thing. And then you have the reticular activating system, which we mentioned last time, right? Reticular activating system is actually all the way through the brain. So it kind of starts here in the midbrain, and it goes all the way down. And the reticular activating system is what's responsible for what? If you don't have an active reticular activating system right now, you didn't finish your coffee, you have a warm Monster in front of you, you want to grab some candy so you can stay awake, because the reticular activating system is what keeps you awake, right? So you take drugs that suppress it, that's going to obviously make you more not as alert, right? So you're going to start getting ALOC, lethargic, comatose, right? And these are signs of increasing ICP, or increasing intracranial pressure, right? You can start causing pupillary changes. What's first, though? You're going to get changes in mentation first, right? And they don't start getting like restless. They start getting lethargic and stuporous and semi-comatose, and this decrease in the RASS score, right? Not the RAS, but the RASS, right? So the Richmond Agitation Sedation Scale. So yes, the RAS will also be suppressed. That's why they're lethargic, right? And also we got some motor tracts getting involved. So now we're going to start compressing the spinal cord on one side. So it's going to start compressing. And now that spinal tract's not going to work, right? Because remember, we have the thalamus up here, which is responsible for all the signals that are going in and out of the patient, right? And now you've just obliterated one of the spinal tracts because you're compressing that area with a herniation. Right, so that's going to cause some like motor deficits on one side, wherever that side is being compressed, right? And the hypothalamus can be involved. So the hypothalamus is where? Below the thalamus, right? It's hypothalamus. So it's right below the hypothalamus. So you've got the thalamus right there in red. Where's a better picture? I'll point it out later, but it's going to be right below it, right? So right below it is your hypothalamus. It's not that big, but it's going to be right below both thalami, right lateral to the third ventricle, or lateral ventricles, and it's going to be going down, and when it starts getting compressed, you're starting to get hypothalamic dysfunction. So what the heck does that mean? That means dysfunction of the hypothalamus, of course. All right, that means that the hypothalamus can't do its job, and what's the hypothalamus's job? Thermoregulation, right? Is to what creates a fever. It's what raises your body temperature, right? So when you have interleukin 1, interleukin 6, and TNF alpha that come with an infection, it goes to the hypothalamus. It's the thermostat of your body, right? It'll raise the temperature. And if you start compressing, it's like, what's going on? Am I being under attack? And you're going to start getting a neurogenic fever. You're going to start getting a fever because you're compressing the hypothalamus until you can't anymore, and the hypothalamus dies. And now you're going to get cold and dead, right? Or then the other problem is the hypothalamus also secretes ADH, or antidiuretic hormone, right? If I have too much antidiuresis, that leads to what? Fluid retention, or an inappropriate amount of ADH. It might be even called a syndrome of inappropriate ADH, or SIADH, right? So SI or SIADH is too much ADH gets released because the hypothalamus is like under attack by this herniation, until the point where it just fails, where it's being compressed so much where you don't release ADH. And what's that called if you don't release ADH? DI, diabetes insipidus, right? So where you have a lack of ADH centrally, right? Which can occur in a neuro patient. They either can have SIADH or DI. We don't really know which one it's going to be. It's a flip of the coin, right? What's going to happen? Is it compressing it a lot, where it's not able to do its function at all, or is it just compressing it and it's a symptom that's happening, right? It's like, hey, my urine output's nothing, and my patient's super febrile. They must be going to septic shock. It's like, well, they have a huge hemorrhage here. It might be something more nefarious, right?
Will hyperpyrexia upregulate like WBCs?
So the WBCs are different results. When your WBCs go up, like sepsis response, surge response, the WBCs are going up, and all the interleukins, everything get released, and that will then trigger the hypothalamus to do its thing. But here, it's the hypothalamus is just doing its thing without any kind of WBC activation. Right, so you're not going to see the WBC elevation. And yeah, that's a good point. You could get a CBC, like I got a fever. You're going to get a CBC, you can get blood culture, you can do all the things, and a CBC shows a white count of 6. It's like, well, what's going on? Why is that happening? Because your white cell count should go up immediately just with an SNS response, right? So
a herniation like that can cause just a fever?
Yeah, straight up fever. All right, their temperature is like 101, 103. It's because they have a herniation happening in front of your eyes. All right, so we're pushing down all these structures here, right? So we have a subfalcine herniation. That's our midline shift, where it's just going left to right or right to left, whatever you choose, depends wherever the issue is, and it's going under the falx cerebri, or that's that hard tissue that's right there. Can it tear? Not really. If it's like slow like that, but yeah, like in trauma, yeah, it could tear across, right, and cause definite shearing forces across that brain that's pushing across that falx cerebri. And then we have uncal herniation, which is pretty common. That is where we have the uncus of the temporal lobe is being pushed downward through the temporal, through the, what's our guy here? through our little tentorium here, right? So tentorium, this is where the tentorium is, the brain's been removed. You can see the tentorium is like the basement of the brain, right? Yes, you have the basilar skull there, but then you have the tentorium, which is an extension of that, right? And it stops right there, right? So you see in green right there is our tentorium, okay? And that's going to be an issue because the uncus is going to then push over into it, right? So here's the falx cerebri in pink there, and in dark purple there is our tentorium, and we have this little opening there, which is cool. That's where the brain stem's going to be, but we can push into it with herniation syndromes, right? And then we have central herniation, which is obviously a lot worse than just a uncus that's coming through. Now it's both uncuses. Both my uncles have come to visit. Right now, everything's pushing downward. Everything has been huge. Cerebral edema is pushing down. Number 2 right there. Everything's pushing downwards, right? These are all supratentorial herniations. Why is it supra? Supra means above the tentorium. So we have a uncal, central, cingulate, and transcalvarial. Transcalvarial usually is not survivable. That's where you don't have a midbrain. You might have a midline shift, but it has also shifted outside the skull. So you have brain tissue outside the skull, which is never usually recoverable. Okay, so these are our supratentorial herniations. Can you have infratentorial? Yes. Like I mentioned, the cerebellum is a very, very high risk area because it tries to expand, it can expand upwards, and it can still start compressing the midbrain as it goes upwards. Or it can go downwards and start compressing the medulla. Is the medulla important? Steven Seagal thinks it is, right? So that's going to cause a compression of the medulla, and you're going to have an absence of heart rate and an absence of respirations. Okay, so these are all infratentorial herniations. So this one up here, we supra or infra? This is where this fracture happened and cause a bleed to occur. Start pushing things aside, starts causing a midline shift or a subfalcine herniation, cause a little uncal herniation as well. Is that a supra or infratentorial? That's supra. So infratentorial would be this guy right here. I got a bleed inside my cerebellum, right? I got a bleed within the box within the box. So here's my box right here, and there's my box right there, right? So I got a bleed or edema. I got a mass right here that's below the tentorium. Where are things going to push? They can push upwards and push that midbrain directly, or that brainstem directly, or it can push in the medulla directly. It's much, much higher risk. All right, these patients usually are awake and in the corner, they got a CT scan, they're fine, and you go back to assess them and they are dead because their cerebellar mass or bleed because you're waiting for the scan to come back and it shows a massive hemorrhage, a massive edema.
So, stupid question, but the infratentorial just means that the bleed or like the point of pressure is below that tentorial.
Correct. So infratentorial just means below the tentorium. That's it, right? So we have supratentorial and infratentorial bleeds, right? So those are our examples of herniations. Obviously, there's a pretty bad herniation. That's a supratentorial, but it's pushing everything to the side, right? So normally our ventricles should be nice and open like this. Probably not that open, but you can see all these things have been pushed over to the side, right? Usually the ventricles are midline. They're lateral ventricles are on both sides, and now it's all been pushed over to the side, okay? So you have upward tonsillar, that they call this the tonsil herniation, or downward tonsillar. Obviously downward is a little more concerning because now it's pushing on the medulla. What's the medulla for? It's for a heart rate and respiration. So when you have a Cushing's triad, right, which is where you have heart rate variability and respiratory variability, well, that makes sense. It's pushing on the pons and it's pushing on the medulla, right? So I'm going to have that variability. And what else? So it's going to cause in this herniation syndrome is obviously much more high risk compared to a supratentorial. There's a little room to grow, especially if you're elderly or you drink alcohol. You're going to have a brain that's a little less volume.